Now let us look at the next important topic, and that is nails. Now in this case, how the procedure happens decides the code. So what have you done with the nails? Have you done the debridement, excision, evacuation, biopsy, repair? And depending upon that, we decide the code. So these are certain codes which are related with the nails, and you will see that this is the code for the debridement. Then this is the code for the avulsion, evacuation, excision of the nail and the nail matrix, and then the partial or complete ingrowth or deformed nail. So these are the code for the various treatment we carried out on the nail. Then this is the biopsy of the nail, this is the repair, reconstruction, wedge excision. So what you have done will decide the code. Now pay attention to the various modifiers that we use as far as the fingers or the toes are concerned. So here we have the modifier which are called as the Heckpex modifier, which we are going to learn it later. But these are the modifier that we use it for the various fingers. So if it is a left hand and second digit, we will use it F1. So that will talk about the laterality of the particular finger. So let us look at this example. A 55-year-old male present in the office with an ingrown toenail on the right and the left foot. The procedure was discussed in detail and the patient elected to have it performed. The right foot was prepped and draped in sterile fashion. The right greater toe was anesthetized with 50-50 solution of 2% lidocaine and 0.5% mercaine. A mini tourniquet was placed around the toe for the hemostasis, in which the part of the nail plate and the matricectomy were performed. Matricectomy is nothing but the removal of the nail matrix. Phenol was then applied, the toe was then flushed, tourniquet was released and dressing applied. At this time, the patient elected to only have one performed and will return in 2 weeks to the left foot. Code the procedure. So they have told us to code for only the right foot. Though he has a problem in the both, the patient is going to come back for the left foot in the second week. Now what has happened here, that is very important. So what they have done is they have removed the matrix. They have used the word matricectomy. Removal of the matrix is nothing but the excision of the nail matrix, nail plate, that is partial or complete. So that has been performed. So if you see the code 11765, it talks about the wedge excision of the skin of the nail fold. 750, it talks about the excision of the nail and nail matrix that has happened. 730, it talks about the avulsion of the nail plate, and 40 talks about the evacuation of the subinguinal hematoma. So we are going to see what has happened and we are going to decide the code. So yes, B is the right answer because that's what exactly happened. Excision of the nail and the nail matrix. So rather than using the word excision of the nail matrix, they have used the word matricectomy. Ectomy is the removal, and that removal means the excision when they take out the whole thing. And 750 and T5 is for the right foot greater toe. And so we will go with the answer B. Next, we are going to talk about pilonidal cyst. It is a sac-like structure which is filled with a hair and a skin debris that typically occurs near the tailbone at the top of the buttocks area or the crease. And here is concise breakdown. So as far as the pilonidal cyst is concerned, we have the three categories. The first is pilonidal cyst excision by, we have the code, the simple, then you have excision of the pilonidal cyst extensive, and excision of the pilonidal cyst complicated. Now sometimes in your exam they will write the message extensive, but otherwise they will use the the synonyms like deep rooted. If it is a complicated, they will write infected and the patient has written back. So many a time the exact wording is not written in your question paper. So pay attention to that. And these are the code for the excision, where we are trying to take out the pyloneural cyst. But if it is the incision of the pyloneural cyst, we go back to the code 10081 and 10080. So this is the classification. Pay attention. These are the excision code and these are the incision code. And these are the code like 10080 is the incision and drainage, simple, and this is complicated. So when to use the code? So if the cyst is infected, swollen and filled with a pus but not being removed completely, that the doctor carried out incision and drainage, then we will pick up the code 10080. But if the cyst is chronic, recurrent or large and the doctor has decided to undergo the repair, in that we are going to talk about the three different kinds of repair, and then we are also going to cover the adjacent tissue transfer. So what is repair? Repairing injuries to the integumentary system primarily is to close the wound and promote the healing. Sutures are used to approximate the edges of the wound, bringing them together to encourage the healing. This technique helps to restore the skin integrity and can be used for the various types of wound. As far as the repair is concerned, we have the three different types of repair: simple, intermediate, and the complex. And this is the code range that we are going to see. This is the theory that is there in your book. Kindly go through all the theory, and these are the basically the guidelines which are important from the coding point of view. So this is what is there in your book. So what is simple repair? Simple repair involves the superficial layer of the epidermis and dermis or subcutaneous tissue without significant involvement of the deeper structure. Intermediate repair, it includes the layered closure of one or more deeper layer, example fasciae, in addition to the skin. It also includes single layer closure of heavily contaminated wound. So intermediate repair, it happens at the two levels, or if it is a simple wound or a simple repair, but if it is a heavily contaminated wound, that also we can code it under intermediate repair. And the complex repair, it involves more than layered closure, may include scar revision, debridement, extensive undermining stent or retention suture. Now let us look at the important guidelines. When multiple wounds are repaired, add together the length of those in the same classification. That is simple with simple repair. And from the anatomic side, that are grouped together into the same code descriptor. What does it mean? Means don't add together the length of the different classification. So that means simple and a complex wound repair I cannot add together. And don't add together the length of the repair from the different grouping of the anatomical side. So for example, trunk and the face. So there are various anatomical group, and we can add together from the same anatomical group, but we cannot add together from the different anatomical groups. Then sequence first, complex repair, intermediate, and then simple. So in a patient, if all the three repaired carried out and you are supposed to code for that patient, always code the complex first, followed by intermediate and then the simple. When more than one classification of the wound is repaired, list more complicated as a primary and less complicated as a secondary procedure with the modifier 59. If the physician uses a steady strip, do not code from repair. If uses an adhesive strip, we have to code it from the E&M section, not from the repair. Excision plus simple repair, code only the excision. Excision plus intermediate repair, we have to code both excision as well as the intermediate repair. And excision plus complex repair also we have to code both, that is excision plus complex repair. Now there are various terminology that they use in day-to-day practice or even in the CPC exam. Like if it is a simple repair, it will be written as layer with cleaning, simple closure, superficial closure, epidermal closure or dermal closure. If it is an intermediate repair, they will write it layers, layered with extensive cleaning, layered with extensive debridement, multiple layered. Complex repair, they will have the synonym like extensive undermining, retention suture, undermining stent, and scar revision. So pay attention to this terminology because not necessarily in the exam they will write the wording as simple repair. They might just mention that the patient had layered closure. And we have to assume that that means it is an intermediate repair. Now these are the code. So if you see, this is the code for the simple repair, these are the code for the intermediate repair, and if you see, this is means by the body group. So this particular body group has scalp, axilla, trunk, and extremities, excluding hands and feet. And this is same way we have it for the simple repair also. So this body group is very important because we can add together if there is a face, the simple repair of the wound of the face and the ear. If they have given, we can add together because the body group is the same. So let us take example that the patient underwent a wound repair of the scalp, which is 3 centimeter, and repair of the wound on the trunk, which is 5 centimeter by layered closure. So that means it is an intermediate repair. And let us look at this two body part. So if you see, the scalp is here and even the trunk is here. So this is one body group. So what I am going to do is I am going to add this two. 3 plus 5 is a 8 centimeter. And for that I will code this 12034 because same body group, then we can add the repair. And of course both are by the layered closure. So let us take one more example. Here what has happened is the patient has wound on the scalp 4 centimeter and arm 1 centimeter, and then there is a wound on the hand 2.5 centimeter, which is closed by the layered closure. Now what we can do here, first of all we need to find out the body group area. Now all these are by the intermediate closure. So 4 centimeter is the scalp and arm. Now here they have said trunk and or extremities excluding the hands and feet. So arm is the extremity but it does not include the hands and feet. So 4 plus 1 centimeter I can add because this is the same group. But if you see the hand is here. Okay. The body group is different. So I cannot add now 4 plus 1 plus 2.5. But I can add scalp and arm because they come under this category. And in this case 4 plus 1 becomes a 5 centimeter. So for which I will code 12032, and then it is a hand 2.5 centimeter for which I will code 12041. So this is how I'm going to code this because the body groups are different. Now let us take example. Mark cut his hand and arm while working on his car. Dr. Bill applies sutures to both arm and hand wound. An intermediate closure of 16 centimeter was placed in the arm and a simple closure of 3.6 centimeter was placed in the hand. Which code should Dr. Bill report? Now there are mini guidelines. First of all, what has happened is the patient injured into the car accident and he had injury to his hand and arm, and both the wounds are repaired by the different method. The wound on the arm, which was bigger one, it was closed by the intermediate repair, while wound of the hand was closed by the simple closure. So we cannot add those wound together because the classification of the wound is one is intermediate, one is simple. And we have a guideline that whenever you are coding for the two different repair, we have to use the modifier 59. Okay, so we have enough clues. Now we need to zero down our answer. So yes, answer B is the correct answer, because here there are two types of repair that has happened. One is intermediate and one is simple. And in that case, we are going to write them independently without adding them, that because we cannot add the wound from the different classification. And in that case, we will write the intermediate wound first, followed by the simple. And whenever the two different classification of the wound we are writing, we have to put a modifier 59. So we are covering three guidelines here, and that's why the answer is B. Now the next question is, the physician is called in to perform the repair for the 17-year-old girl involved in a motor vehicle accident. She sustained an 8.6 centimeter laceration for her forehead, 5.5 centimeter laceration to her right cheek, 4 centimeter laceration to her left cheek, 4 centimeter laceration across her chin, and 12.5 centimeter laceration to the chest. The wound on her chin required a lead closure. All other wounds required a complex closure. The CPT code to report. Always remember, whenever you have a multiple wound which you need to repair, you need to solve this kind of question. It is better to write it down like this. So 8.6 centimeter, which is your laceration of the forehead. Then there was a cheek and left cheek, right cheek, and then across chin and chest. So out of that, except the chin where it is a lead closure, the rest were the complex repair. So you have enough data with you. Take a minute to understand even the body group area, because you remember that guideline also applies, and then we need to finalize the code. So if you collect the data, you will see that there is a cheek right and left, which we can add it together. That becomes 9.5. Chest is 12. Chin is, of course, the intermediate, and forehead is 8.6. Pay attention to the body group. We can add the body group, and depending upon that, if we put all the data together, C is the right answer. Let us take one more example. A 14-year-old male had fallen on the road while riding the bicycle. He lacerated his forehead about 4 centimeter and left leg 3 centimeter. The ED physician repaired the laceration as follows. In the forehead, he had done the cleaning of the contaminated wound and closed with sutures. The leg was repaired by superficial sutures on the skin. What are the codes for this? So in this case, what has happened is, there are two wounds. One is on the forehead, one is on the left leg, and the forehead wound was clean and contaminated wound and closed with sutures. So though it is a single layer closure, because the wound is contaminated, we have a guideline that the single layer closure of the heavily contaminated wound that have required extensive cleaning and removal of the particular material also constitute the intermediate repair. So what we need to do is, we need to code the wound on the forehead as a intermediate, while the wound of the leg was a superficial suture, so that will be a simple repair. So you have these two important clues with you. Now tell me the answer. So yes, A is the correct answer, because the wound of the forehead, which was closed in a layer, but because it was heavily contaminated, we are going to code it as an intermediate repair. And then we have a wound on the leg. So we will write two codes, and whenever there is a two different classification of the wound, if we are coding it together, we need to put a modifier 59, not 51. So is the right answer. Now the next important topic is adjacent tissue transfer. The codes are 14,000 to 14,302, and usually they use the word Z plasty, W plasty, VY plasty, rotation flap, random island flap, and advancement flap. Now whenever you are coding for the adjacent tissue transfer, it includes the excision. So we do not code for the excision separately. So excision plus ATT, we code only ATT. Now, and we never code the excision code. This is very important. Now, what are the guidelines? The keywords, what I have given you here, these are the keywords, so look for it. Then again in this also there is an anatomical site and anatomical body group. Code each site separately. Again here we do not add the diameter together, and incidental trauma close by the ATT had to be coded from an appropriate repair code. So remember, this is also one important guideline, and excision plus ATT is always ATT. Now here in ATT, one must understand what is defect, and then one must understand what is primary and secondary defect. So for the purpose of the code selection, the term defect, which includes the primary and the secondary defect. So what is a primary defect? The primary defect is resulting from the excision. Like suppose if there is a cancer and you have taken down that cancer, and because of that you create a defect, that is called as a primary defect. And secondary defect resulting from the flap design to perform the reconstruction are measured together to determine the code. So here I have given the detailed description of the primary defect and then the secondary defect. So whenever we are coding for the ATT, so pay attention to this diagram. This will helps you understand why we code only ATT and not the excision. So this is the primary defect. Primary defect means, let's assume that there is a cancer and that has been excised, and because of that there is a defect that has been created. So that is a 2 centimeter. Now to close this defect we create a flap, and we then pull this flap over this defect like a blanket. So for that we have created another defect here, because when I'm creating a flap, I'm going to cut it from here, cut it from here, cut it from here, and then I'm going to pull it over here. So that is called as a secondary defect. So when I'm going to code for this, I will code the primary defect, which is length by breadth, that is 4 centimeter, and secondary defect, which is 3 centimeter by 2 centimeter, that is 6 centimeter. So I'll be coding for directly 10 square centimeter. And since it includes the primary defect, we don't have to code excision separately. This is very, very important concept. Once you understand, you will never make any mistake. So these are examples which are given in your book, and pay attention to that. That this is like, for example, here they have given this, that 1 centimeter primary defect was there, and to close that we have created a flap, and that flap was 2.5 centimeter into 1.2. Remember, whenever we take out the area, the math formula is length into breadth. So the length is 2.5 and the breadth is 1.2 centimeter, that becomes 3 centimeter. So I'll be coding for the 4 square centimeter, because the area 1 is 1 square centimeter, area 2. So what is the formula? Area 1 plus area 2 is equal to this. This is the ATT. And similarly, this is also one more example. So always pay attention to these examples. They helps you to understand your concept better. So these are the code for the adjacent tissue transfer. This is the defect size. These are the code, and these are the body area. And remember, all these three are very important because depending upon that, the code varies. So let us take the example. The patient is 40-year-old Rita Churchill with a biopsy proven squamous cell carcinoma of her scalp measuring 1.8 square centimeter and a square centimeter. And I drew my planned yin-yang flap closure. The flap rotated into the defect with a total measurement of 2 into 3 centimeter, that is total 6 centimeter. The donor site were closed and the flap inset in layer using 4.0 monocryl and a skin stapler. Loop magnification was used. The patient tolerated the procedure. What CPT code is reported? Now here what has happened is the answer will be 14020 in this case, because this is the 2 into 3 is equal to 6 centimeter is the measurement of the flap, and the defect is 1.8 centimeter. So if we have to use the CPT language, the 1.8 centimeter is the primary defect and 6 centimeter is the secondary defect, and we add both the defect together, that becomes the 7.8. and the area is a scalp. So here if we take down this table, here they have given the body area and this is the defect size. Our defect size is 7.8, that is 10 square centimeter or less, and this is the scalp area, so the code will be 14020. Now let us take this example. A 45-year-old male is in an outpatient surgery to excise a basal cell carcinoma of the right nose and have reconstruction with advancement flap. The 1.2 centimeter lesion with an excised diameter of 1.5 centimeter was excised with the 15 blade scalpel down to the level of subcutaneous tissue, totaling primary defect of 1.8 centimeter. Electrocautery was used for hemostasis and adjacent tissue transfer of 3 square centimeter was taken from the nasolabial fold and was advanced into the primary defect, which CPT code is reported. Remember here, what they have given is 1.2 centimeter of lesion and 1.5 centimeter of margin. So sometime you get confused, but luckily to your luck, they have given the primary defect area. So we don't have to use the formula excision plus 2 into the margin. We don't have to use that because we already have the answer. And in this case, the total defect was, primary defect was 1.8 centimeter and advancement flat tissue transfer was 3 square centimeter. So primary defect plus secondary defect, it becomes 4.8 square centimeter. And what is the area? The area is right nose. Now we know that whenever we have to write the ATT, we do not code the excision. So B is not the correct answer, and DE is also not the correct answer because it is not a graft, it is a flap, and they have used that adjacent tissue transfer. So we will require a code for the ATT, and then we'll just see what's the answer. So yes, the total area is 4.8, body site is right nose, and if you see the code 14060, it is adjacent tissue transfer of the rearrangement eyelid nose. Our area is nose, and here it is defect is 10 square centimeter or less. So we will go with the code. So let us take one more example. A 39-year-old male is here to excise a melanoma on his right cheek and have reconstruction with an advancement flap. The 2.5 centimeter lesion and the margins required to adequately excise the lesion is 0.5 centimeter, totaling a primary defect of 4.5 centimeter. An adjacent tissue transfer of 8 square centimeter was taken from the adjacent area and was advanced into the primary defect. What are the code for this procedure? So remember, we have the primary defect which is 4.5 square centimeter, and then the secondary defect which is of 8 square centimeter. And since it is the ATT, for that we just write the code for the ATT, and the total area we calculate the primary defect plus secondary defect. And remember, we do not write the excision code. So if you see the question option C and D, which includes the excision code, they are not the correct answer. Okay, because we write only one code, and that is the ATT code. So C and D goes away, it remains with A and B. So 4.5 centimeter plus 8 square centimeter, it becomes 12.5 centimeter, and that's why option A is the correct answer. B includes only 10 square centimeter or less, but ours become 12.5, and that's why we'll go with the option A. Now let us take one more example. A 29-year-old female involved in a motor vehicle accident was brought to ED via ambulance. The patient sustained several facial trauma. After comprehensive examination, it was determined that the patient's trauma was isolated to the mouth area, and complex full thickness repair of the was necessary. Due to the location of the wound, the tissue adjacent to the wound was stretched just enough to cover the repair the wound. The patient is expected to have minimal scarring, which procedure best describe the encounter. Now here, remember what has happened. Here the patient underwent a motor vehicle accident and she had a extensive trauma in the mouth area, and for which the complex full thickness repair was necessary, and due to the location of the wound, tissue adjacent to the wound was stretched just enough to cover the repair. Now we need to check what's the answer is. So at the beginning of the adjacent tissue transfer, there is a very important guideline that for the full thickness repair of the lip or eyelid, see the respective anatomical subsection. And so in this case, there is a complex full thickness repair of the lips was happened, and for which we cannot pick up the code from the adjacent tissue transfer, though the tissue has been taken from the adjacent area, but there is a full thickness repair, and that's why we cannot code from the 14,000 series, but we will have to go to the respective tissue anatomic location, and that's why 40654, it is a repair of the lip over 1/2 vertical height or a complex up to vertical height and repair. But since we have only one code from the 40,000 series, we will be going with that code. Let us take one more question. A patient underwent an excision of 2.1 centimeter diameter malignant lesion on her nose, and 11.2 square centimeter adjacent tissue transferred was required to repair the primary and secondary defect. How should you code this procedure? Remember, for the ATT, defect 1 plus defect 2 is equal to ATT. We do not code the excision, and that's why we can eliminate all the wrong option, because 11643, 11646 and 11443, these are the excision code. And remember, whenever there are multiple codes, if one code is wrong, that option is wrong. So we will code only the option B, because here 11.2 plus 2.1 becomes the 13.3. So we'll be coding for that, and the area is the nose. So yes, B is the correct answer, because what our area is 11.2 square centimeter plus 2.1, because this is the excision diameter and this is the adjacent tissue transfer, so that becomes 13.3. And if you see the code 14060, it includes only 10 square centimeter and less. And for ATT, we do not write the excision code.